Um, we're going to move ahead to the next talk by Dr. Raees. Basically, he's going to talk about appropriate use criteria in the Cath lab. I think this is a very important topic and we all talk about it, but I think it's important to know.
All right, thank you for the invitation. And in order to keep me on time as well, I have a recorded presentation here. Please let me know if there's any issues.
Okay, go ahead, please. We don't hear your voice.
Okay, I'm sorry that is not...
There is a recording, Dr. Hanif.
We have it over here, so we can play that one. Is that okay?
Oh, excellent.
Yeah.
Yes, I will stop share. There we go.
We'll do that.
Is it going to play on your end?
Trying to figure out about audio. I think we can see the slides, but audio is not there. So I think they're unable to play the audio. They have the PPT, but they're unable to play the audio. So maybe you can try again.
Okay, give me a moment here. So is this, I'm sorry, can you hear when this is playing?
No, we can't hear.
No, okay, well then I'll just navigate through and see how it goes. So when talking about appropriateness use criteria, and thank you for the invitation to speak at your conference. I have no disclosures related to this talk. So in looking at appropriate use criteria, I think it's important to think about how this was developed. There was the Research and Development Corporation initially was founded with the focus on military analysis, but subsequently became a, I'm sorry, this is going to happen here. Subsequently was a nonprofit focusing on scientific, educational, and charitable purposes for the public welfare. And they determined a scientific method based on evidence and expert opinion and statistical analysis to identify underused and overused care and to apply this for individual patient scenarios. AUC is now used by multiple medical specialties. And the one of the first in the cardiovascular realm was New York State PTCA appropriateness, which 9 experts put together 1,600 scenarios and looking at random audits of hospital data and a publication here with a table on the right. There were multiple indications, and I boxed in red those that are applicable for today's AUC. And they had 4 categories: crucial, appropriate, uncertain, and inappropriate. And I boxed in green those that would kind of fall in today's appropriate, where a good chunk of the cases mapped to. However, there was a significant amount of uncertain cases, which the authors concluded would required more research. So in 2009 here, the AUC document supported and developed by multiple different societies, and mapping this to NCDR data, about 70% of the cases were for acute coronary syndrome and about 30% for stable angina. Most of the ACS, as mentioned in earlier talks, mapped to appropriate, and about half of the stable angina. However, a good chunk in the uncertain and inappropriate categories. This did create some sensational headlines here about billions of dollars being spent on inappropriate, which the press included uncertain and inappropriate in the inappropriate category. And we already saw this shifted bell curve on the left, where there are some hospitals following or with few inappropriate, but there are definitely some outliers. So this document has been updated mildly in 2012, and then for ACS again in 2016, and for stable angina in 2017. And here's some of the differences. Number one, in the nomenclature, it was they went from inappropriate to rarely appropriate, and from uncertain to maybe. And these are probably more appropriate labels, as I'll talk about in a bit with some case examples. The criteria development was modified. There's now a more balanced rating panel. Prior, there were 8 clinical physicians, including some non-cardiologists and a health plan official. Now there's 5 interventionalists, 5 CT surgeons, and 5 clinical cardiologists, and separate writing and rating panels. Symptom classification was very subjective using the Canadian cardiovascular classification, which is based on symptoms when patients are walking blocks. I listed a couple cities here in the US. Some of the blocks, average blocks, are squares, some are rectangulars, very different meter lengths. Now it's just symptomatic or asymptomatic. Medical therapy aligns more with real world practice. However, there still is no mention of patient tolerance. As we know, patients do have some side effects with anti-anginal therapy. Markers of disease severity have been updated. There was a heavy reliance on non-invasive imaging, which can be quite subjective, and does have a pretty good false negative rate, at least in terms of extent of disease. FFR is now included, and syntax score is expanded. And some more contemporary scenarios like revascularization before renal transplantation or structural heart procedures. So here's just a quick slide that's available or figure in both documents, just kind of the process of how the writing committee and the rating panel work. So the scope of indications here we see for the ACS document and the stable ischemic heart disease document, things that are considered. Diabetes is weighted in here, and as I mentioned, intracoronary physiology as well as anatomy, and for ACS, important for fibrinolytic therapy, as cath labs are not readily available across the country here in the US. So here's a figure from the AUC document for ACS. We see our unstable angina and STEMI, then our STEMI over here. And most of these will map to appropriate or may be appropriate for revascularization. But then there's also the non-culprit vessel we have after reperfusion or revascularization. And the one that stands out makes sense in terms of it would be rarely appropriate to revascularize a non-culprit artery in a stable patient who's asymptomatic with an intermediate stenosis. Clearly, that patient needs a little more investigation. So here's the statement for the stable ischemic heart disease document. We did see some of this earlier. We see the anatomy, 1 vessel, 2 vessel, 3 vessel left main, and then post-bypass here, and some of those contemporary transplantation or structural heart disease scenarios. Then we have in the columns here, asymptomatic and ischemic, and then anti-anginal therapy and the degrees, and then PCI or CABG. Green is appropriate, yellow is maybe appropriate, and red is rarely appropriate. Looks complex at first, but spending a couple minutes reviewing it's pretty intuitive, very helpful, can be found on an app or easily pulled up online or even just posted in the lab, and should be part of QA reviews. So in terms of looking at what did the 2017 update do? So here's patients from New York State in 2014, where the 2012 AUC and the 2017 AUC were applied. And we see over here on the image on the right, or the table on the right, there were 911 inappropriate PCIs on the 2012, whereas in the 2017, those same cases, there was only 171 rarely appropriates. So this seemed to align more with real world practice. And when we take a look at those inappropriate cases from 2012 and looking at which ones switched over, only 140 of those became rarely appropriate, and 760 of those mapped to maybe appropriate. That is outlined over here on the left, and the vast majority of the time it was because the the weight of the non-invasive testing was lowered, and things such as symptoms and intracoronary physiology were included. Here's a case example, 71-year-old male, known CAD, stage 3 chronic kidney disease and hypertension, new onset heart failure, EF 15%. He stabilized and then went to the cath lab. We have a CTO of his RCA, CTO of his circ, and significant left-sided disease. His STS score was above 4% for inpatient mortality if he underwent bypass surgery, and he was evaluated by the cardiothoracic surgeons who felt he was not a great surgical candidate. So he underwent a DK crush, 1 stent in the Raees, 2 in the LAD, well-opposed expanded stents. Here's at the left main ostium. Looking at him, he has left main disease, bifurcation involvement, and a high syntax score. No matter what symptoms or medical therapy he's on, he maps to rarely appropriate. But he underwent PCI. If this was labeled inappropriate, it just makes it look like it shouldn't have been done. This was his only option, and that's okay. We accept that. By the way, we look at these every 6 weeks, and this is by far and away the highest rarely appropriate scenario that we have at our institution, and we really confirm that there has been a surgical evaluation first. Another case, 60-year-old male who's a pilot and needs to renew his medical certificate for the FAA. He's had a cabbage in the past, lima to LAD, vein to the OM. He had a negative stress test. He has mild angina, doesn't tolerate anti-anginal therapy, and he's forced to have an angiogram. He has a lesion in his vein graft, radial access, hockey stick guide, 1 stent, same-day discharge. Now, he ends up mapping to rarely appropriate as well, low-risk findings on the non-invasive stress test. He's not on anti-anginal therapy despite having ischemic symptoms. And however, if let's just say he was on a beta blocker, he gets pushed up to maybe appropriate. Let's say he's also on amlodipine, he ends up being appropriate. And so this is just a scenario that we accept, and that was for his quality of life. He understood why we were doing it, as did the providers.
So you have 1 minute.
Role of AUC.
You have 1 minute.
All right. Thank you. Just about done here. The role of AUC is really creating a framework to look at overall clinical practice. It's a clinical tool to look at our therapeutic options and to educate patients and providers and staff. It's a research tool, has been pointed out in some other talks earlier, looking at utilization patterns for individuals, hospitals, groups, and regions. Administrative tool for quality assurance, as I mentioned, it's part of our standard QA for the Cath lab. But it's not something which in individual cases should be judged, and not for which reimbursement should be made for individual cases. So here's our experience here. The U.S. registry, 50th percentiles in red. We're in blue. We take this very seriously, and it's now a standard part of our Cath lab review. Thank you for your attention, and sorry for the hiccups here.
Thank you very much. We are going to go ahead, for the sake of time, move on to the last talk of the day by Dr. Wasef Qureshi on continued privileging of operators.